All right, let's take a look at multi-systems trauma. We've talked in brief about chest trauma, abdominal trauma, head trauma, kind of isolated them to the individual body regions. But multi-system trauma patients often have life-threatening injuries when you have more than one body system involved. So multi-system trauma patients are typically more seriously injured and often need to be moved quickly to a facility that can care for their multi-systems trauma, and that's often a level 1 or level 2 trauma care facility. This requires teamwork, it requires timing, and transport decisions are key to make the proper management of these patients. It wasn't that long ago that in certain parts of Iowa, a patient may have suffered multi-systems trauma and may have had to wait 20 minutes to 30 minutes for an ambulance to arrive. The ambulance would spend another 20 or 30 minutes on scene, take the patient back to a hospital where the doors were locked. They needed to be buzzed in, and the OB nurse who drew the short straw was taking care of the ER that evening. The physician was at home sleeping, lab, radiology were at home sleeping, and some 2 hours later, decisions were made about transporting this patient with serious life-threatening trauma. We know now, based on the golden hour from Dr. Crowley out of the Shock Trauma Center in Baltimore, that if a person has a serious life-threatening injury and can be on a table with a skilled trauma surgeon within an hour of their injury, there's a good chance they're likely going to survive that injury. Now, those patients who die within the first several minutes of their insult or their traumatic injury either exsanguinate or they bleed to death or have a major brain injury. So there's no treating those folks. But then those people that die within the next couple hours, if we can get them again to that level 1 or level 2 trauma care facility quickly, there's a good chance that they will survive their injuries. Most critical decisions on determining how severely injured the patient is are based off of the CDC guidelines, which we will cover here on critically injured trauma patients. And when we know that we're dealing with a critically injured trauma patient, as an EMS provider, our goal is to do what is necessary on scene and move the patient quickly to that level 1 or level 2 trauma care facility. So that may require us to make decisions as to whether we should stay on scene or whether we should load and go. We're not advocating that with certain patients you just scoop and run. You still need to do an assessment. You still need to determine if certain physiologic or anatomic criteria is present. You still need to start working on the ABCs. But at some point, within 10 minutes, move the patient from the scene en route to a level 1 or level 2 trauma care facility. For some of us, we don't have a choice of whether we should transport or not to a level 1 or level 2 trauma care facility because they're too far away. Right now, the current recommendation in Iowa is if you're within 30 minutes of a level 1 or level 2 trauma care facility, then you would take the patient directly to that level 1 or level 2 trauma care facility, even if it meant bypassing your own hospital. And that's been a hard pill for some smaller community hospitals to swallow. But remember, we're in this for what's in the best interest of our critically injured trauma patient. The recommendations that are being considered would extend that time here in Iowa from 30 minutes to 45 minutes. So if you're within 45 minutes of a level 1 or level 2 trauma care facility, you might bypass your local facility and take them directly to that level 1 or level 2 trauma care facility. Now, determining how severe a trauma patient is injured requires us to do an assessment. Mechanism of injury by itself, or how the injury occurred by itself, is no reason to base how severely injured the patient is. As an example, if I get paged out to a motor vehicle collision, or a motorcycle accident, as an example, I can't make the assumption that the patient, just because they were in a motorcycle accident, has a serious life-threatening injury. I need to see the patient, I need to assess the patient, and then make that decision. Now, in making that decision, the first thing that we're going to look at is physiologically, how has this injury affected the patient? So we're talking about vital signs. If the patient has suffered an injury and they have an altered mental status or a GCS less than 14, then they have a head injury, and that makes them a high priority. If the patient is shocky or hypotensive, has a systolic blood pressure less than 90, then that might indicate that they're in shock, and if you don't see any severe hemorrhage, that they're probably bleeding inside and would need whole blood and a trauma surgeon. If they have abnormally slow respiratory rates, that could indicate a head injury and a later stage of shock as well. If there is no physiologic criteria that would make this patient a high severity, then we look at the anatomic criteria. What type of injury did the patient suffer? Any penetrating injury to the head, the neck, the torso, or the extremities above the elbows or above the knees would make the patient a high priority patient. If they have chest wall instability or deformity, like in the presence of a flail segment, that would make them a high priority. If they have 2 or more proximal long bone fractures, so we're talking about bilateral femur fractures here, or bilateral humerus fractures. If they have crushed, degloved, mangled, or pulseless extremities, if they've got an amputation below the wrist or the ankle, if they have pelvic fractures or an unstable pelvis, if they have an open or depressed skull fracture, or if they're paralyzed. If they have no physiologic criteria, their vital signs are stable, they're alert, awake, and they don't have any of those injuries that we just talked about, then we would look at mechanism of injury. So this is the third step in our process. In the absence of anatomic or physiologic criteria, we have to look at the mechanism of injury to give us a high degree of suspicion that they're not showing any signs or symptoms of a serious life-threatening injury yet, but we need to constantly monitor them because they could develop signs of a life-threatening injury. So mechanisms that create potentially life-threatening injuries are falls, but here we're talking about falls from greater than 1 story, and they define a story as 10 feet. Intrusion into the patient compartment during a motor vehicle collision, ejection from the automobile, death in the same passenger compartment. So if we have 2 people riding in the front seat of a motor vehicle and they strike a bridge abutment and one of the patients is dead and the other one is still alive, that live patient was exposed to those same traumatic forces as the dead patient and may have a life-threatening injury. If the vehicle telemetry data is consistent with high risk of injury, so in other words, a report that you might get from OnStar. If there is no serious mechanism, then the last thing that we look at are special patients and their considerations. As an example, we know that older adults do not efficiently compensate for shock. They don't do trauma well. And children may benefit by transporting them to a pediatric hospital rather than a general trauma center. Children also compensate better than adults when it comes to shock or trauma. Patients who are taking anticoagulants, who may bleed easier, don't tolerate trauma as well. Pregnant patients, it's not so much that they don't tolerate trauma, it's just that really dependent upon the time of their pregnancy. As an example, if I've got a woman in her third trimester of pregnancy, I know that she has increased her blood volume by 25% to compensate for the developing baby. Although her blood volume has increased 25%, her red blood cell count has not. So she has more blood, but she's slightly anemic because her red blood cells didn't increase. At any rate, she can lose a significant amount of blood before she shows any signs of shock, even though the developing baby is having issues with perfusion. So, caring for a multi-systems trauma patient is something that we should practice. We should determine what the roles of the responders are, who's going to be doing what. And en route, you can do that. You can review the roles that each member of the crew will have, and they can talk about what it is they're going to do when they get there. But first and foremost, upon arrival, we're making sure that the scene is safe. Remember that if you're dealing with an auto crash, that there still will be somewhat traffic. It may be down to one lane. It may be directed on both sides of the accident by law enforcement. What we see many people do in law enforcement concerning traffic control, particularly if it's on a highway, is they'll block the road off on either end of the mile and divert traffic around the section or around that mile. So that there is no traffic in there while people are trying to care for multiple injured trauma patients. Now, with penetrating trauma, here we're talking about a knife, a gun, an ice pick, that sort of thing. Remember that those are crime scenes and that if law enforcement isn't present, the assailant may still be on the scene and the scene would be unsafe. So once you make sure that the scene is safe, you're going to perform your primary assessment, which looks at the ABCs. In the trauma patient, we want to make sure that their airway is open. If it's not, we're going to open it with a jaw thrust if they're unresponsive. We also want to make sure that it's patent and that it maintains its patency. One of the worst things we can do is open the airway of a trauma patient, slap an oxygen mask on them, and then walk away to do some other things without being constantly vigilant of keeping that airway open. So we have to ensure that it is open and maintainable. We look for breathing, adequate oxygenation, adequate ventilation, listen to lung sounds. We look for serious life-threatening hemorrhage, either internal or external, and if it is external, we're going to control that hemorrhage. And once we've ruled out all our serious life threats, and we have determined based on our ABCs that the patient has a multi-systems injury with some sort of decline in their vital signs or a certain type of anatomic injury, then we know we need to urgently move the patient and transport them to a level 1 or level 2 trauma care facility or do a scene flight or call it some sort of trauma activation at the local emergency department. You want to give a report to the trauma team. That's one of the more important things you can do, and it's best the sooner you can do it, the better. If you're giving the report, 2 minutes out, that isn't really helpful to the emergency department staff. Some still may have to call in radiology. Some still may have to call in lab. And if they're just getting the information for the first time, 2 minutes out, then we're going to hold that patient up waiting for those resources. So in a scenario with critical injuries, you're going to follow priorities determined by your assessment. You're going to follow the out-of-hospital trauma triage destination decision protocol, at least here in Iowa. You also want to show a good judgment. In other words, if I have in my initial assessment a serious life threat and my patient is deemed to be a high priority, I can postpone taking vital signs until I get the patient in the truck and are heading to the hospital. Now, if you're a non-transporting service, there's certainly things that you could do while waiting for ALS. But once ALS got there, if the patient were extricated, they were out of the vehicle, you could start or you could continue your assessment and get things like a good set of vitals. Excuse me. And then remember to give that hospital staff time to prepare for your arrival, so the sooner you let them know what you have, the better. And this just repeats what we just said. Now, depending on we're just repeating that again. So we want to limit scene treatment to things like stabilizing the cervical spine, suctioning the airway, inserting OPAs or NPAs, restoring a patent airway, ventilating with a bag valve mask, administering high concentrations of oxygen, controlling bleeding, and then immobilizing the patient, which necessarily doesn't mean a hard board. Certainly could be a scoop stretcher, certainly could be a vacuum mattress, or certainly could be the cot itself. Ensuring scene safety is paramount, particularly with multisystems trauma. There's a lot of people running around, and if traffic is still being allowed to pass, we've had providers who have actually been run over by cars that are passing by the accident scene. Once the scene is safe, your priority is your ABCs. Make sure the airway is open and maintainable. Perform those things that you need to do emergently, like opening an airway, suctioning an airway, administering oxygen, assisting ventilations, controlling hemorrhage with a tourniquet, those sort of things. And then adapt to the situation. If I don't have or can't find any serious life threats, the physiologic criteria is not there, the anatomic criteria is not there, the mechanism is not there, then I have time to stay and provide the stabilization and treatment that I've been trained to do. Now, trauma scoring is something that some services do. Not all services do it, but some do. It's a numerical rating system for trauma. It assigns a number to certain patient characteristics to create a score. And, of course, the higher the score, the more severely injured the trauma patient is. So it objectively helps describe the severity of the injuries. That will also then guide or help you determine which hospital this patient should go to. And it also helps trauma centers evaluate the care of similar patients. So the trauma scoring that we're most familiar with is the revised trauma score. It takes a piece of the Glasgow Coma scale or score, takes in account the systolic blood pressure as well as the respiratory rate. Whatever you do concerning these trauma scores, it's important not to let it interfere with actual patient care. So here's a diagram of the revised trauma score where you can see based on the finding, it is assigned a number. And I misquoted earlier saying the higher the score, the more severely injured the patient is, and that would be not true. The lower the score, the more severely injured the patient would be. If I had a great Glasgow Coma scale, my pressure was adequate, and my respiratory rate was normal, the highest score I could get would be 12. So multisystems trauma is a serious condition in which two or more major body systems are injured or affected. And because two or more major systems are affected, these patients often have life-threatening injuries. It's important that we do acknowledge or recognize that this patient has multi-systems trauma. And if we're dealing with multiple patients at a scene, we have to triage patients to determine who is the most seriously injured and who should we be treating first and transporting first. Transportation should be prompt, whether that's by air, whether that's by ground, limiting our on-scene time to no more than 10 minutes, and choosing the correct destination, whether it be the local hospital or a level 1 or level 2 trauma care facility, is going to be vital for the survival of the patient. Now again, the CDC has issued guidelines for trauma triage and transport, and that's what should be used to help guide your decisions. And that's what Iowa uses when they did develop their out-of-hospital trauma triage destination decision protocol. The revised trauma score is one method of classifying trauma patients by severity. Again, the nice thing about scores is that they're pretty universal. If you're going to score a patient 12, it's likely, as long as they don't deteriorate, that the next person would score them 12 as well. So they're more reliable, they're more objective, and they help identify those patients who are more seriously injured. Your primary assessment should determine whether or not this patient has a life-threatening injury, and if they do, remember to limit your on-scene time to no more than 10 minutes. You want to use the physiologic criteria and the anatomic criteria to decide whether to go to a local hospital or to bypass that local hospital and go to a level 1 or level 2 trauma care facility. Now, mechanism of injury, along with some of those special considerations, again, if I have that patient that has no physiologic criteria, meets no anatomic criteria, but has a mechanism that could produce an injury, I'm going to take them back to my local facility and reassess them frequently. You want to ask yourself, is your patient seriously injured or potentially seriously injured based on mechanism? Should I expedite my scene time, keeping it less than 10 minutes? Just because we have 10 minutes doesn't mean that we should take the full 10 minutes. If we can get a seriously injured trauma patient off the scene within a couple minutes, that's something that we should strive for. What is the most appropriate transfer destination for this patient is something that you would ask yourself as well. All right, if you have questions, you know how to get a hold of me. So